Hi, good afternoon, everyone, or good morning, or good evening. Welcome to our webinar education series. Today's topic is hereditary stomach cancer syndromes. I'm just going to go over a couple of housekeeping and just a couple of notes. So first of all, we want to thank Melyssa for being here. We also want to thank our sponsor, Taiho Pharma Canada Inc., who is the sponsor for our education series. Just a couple of things. If you want to ask a question, please do so either preferably in the Q&A section or in the chat section. If you actually would like to ask your question live, then put up your hand and we will get to you. So again, thank you for joining us. We're sure that this is going to be a really interesting topic. Over to Katie.
So thank you so much for joining us, everyone. I'm already looking at the participant list, and it's lovely to see some of the familiar faces in the virtual crowd. So welcome, everyone. I would love to introduce Melyssa, who is our presenter today. So Melyssa Aronson, she is our Senior Genetic Counselor at the Zane Cohen Centre for Digestive Diseases at Mount Sinai Hospital. She is the Assistant Professor in the Department of Molecular Genetics at the University of Toronto. And she's been with us from the start. On a personal level, she's actually been my genetic counselor since 2011, same for Teresa. And really, she's been an instrumental part of the My Gut Feeling team. So thank you so much for joining us, Melyssa.
Thank you so much. It's really a pleasure to be here. And thank you to all the people joining in from wherever you're joining from. And if you're watching this on a recording after, I know some people mentioned they couldn't make it. So welcome to you afterwards, if that's the case. So I'm going to actually share my slides. And hopefully you can see them. So the topic that I was asked to present about is on hereditary stomach cancer. As Teresa and Katie mentioned, I work at Sinai Healthcare Systems, and we have a very special program that takes care of families with hereditary stomach cancer. So a huge multidisciplinary team, including surgeons and gastroenterologists and our pathologist and dietitian and myself. So we have a specialty and a real interest in this, which is why I'm always really happy to talk about this condition. So let me see if I can advance my slide. Okay, there we go. So I always like to start with this this one saying, because I think it's, even though I'm asked to talk about hereditary cancer syndromes, I think it's important for people to have an idea of what that means, because that maybe not everybody understands what that we're talking about. So all cancer has genetic mutations, because really what a cancer cell is a cell that's growing out of control. And the thing that controls our cells' growth, and all of our cells, including our stomach cells, have about 20,000 genes inside of them. And part of the job of some of these genes is to control our cell growth so that our cells do not grow out of control. So if a cell is growing out of control, something went wrong with one of the genes that's supposed to control the growth of the cell. So any cancer that you look at, you're going to find genetic mutations in them. But not all cancer is hereditary. So if you were to take out a stomach tumor and examine the genes inside that cancer, you're going to find mutations. And I gave an example here. One of the more common mutations is in a gene that we call TP53. 90% of cancers have mutations in this particular gene. It's a very important gene for cell growth. But the question is the TP53 mutation in all the cells of your body, including all your normal cells? And we usually look at red blood cells, actually white blood cells, but your blood cells, to check normal cells. So the question is the mutation just isolated to the cancer, or is it in your blood cells as well? And if you take a blood sample and look inside, if you had a hereditary syndrome, you would find the same mutation in your blood cells, which means you were born with that mutation that you likely inherited from your parents. And every single cell in your body has the same mutation. This isn't something just isolated to the cancer. And in the example of the TP53 gene, if you were born with a mutation in this particular gene, then you would have a genetic condition that we call Li-Fraumeni syndrome, which predisposes to lots of different types of cancer. So that's really the difference between what we call sporadic or not hereditary genetic mutations, and hereditary genetic mutations, which is something you're born with. So how can we tell the difference? Well, often it's the presentation of the cancer. So the cancers that are, the genetic mutations that are sporadic, where the genetic mutations isolated just to the tumor cells, it's something that wasn't passed down from your parents and something that you can't pass down to your children. And usually the people that present with this kind of mutation in their tumor are diagnosed at an older age. They often don't have a lot of family history of cancer, and they don't usually present with a lot of multiple primary cancers, meaning that they don't have stomach cancer history with a past history of colon cancer and maybe a past history of endometrial cancer. That would be multiple cancers in the same person. And that's opposed to the hereditary mutations or hereditary syndrome, where someone's born with this genetic problem in all the cells of their body, making multiple cells at risk for developing cancer. And this is something that's inherited from the parents. It's something you can pass down to your kids. And often it's occurs in a person who's younger than we would expect to be diagnosed with that type of cancer. Because they were born more susceptible to getting cancer, their cancer may develop at a younger age. We also usually, if we look at the family history, we'll see cancer coming through the generations of the family. And we may also see multiple cancers in that same person. So if you go through their history, they might have had different cancers at different times in their life, not because the cancer spread, but because multiple cells have turned into cancer. So this is just an example of a gene that we call MLH1, and routine testing on our MLH1 gene or tumor, if we, now every cancer that we remove, at least in Ontario, we do some testing on the tumor sample to see if the MLH1 protein is there. And if the protein's missing, it suggests there's an issue with the MLH1 gene. So 90% of the time, when we see this missing protein that suggests a problem with the MLH1 gene, it's not hereditary, it's sporadic. And that means it's occurring in older people. There is no family history of cancers. They don't have multiple cancers themselves. So the MLH1 gene problem is isolated to the tumor sample. About maybe 5 to 10% of the time, it would be suggestive of something hereditary. And that person would likely have been diagnosed younger with multiple generations affected. And if there's a gene mutation in MLH1 in all the cells of your body, that causes a condition called Lynch syndrome. And so this is really the difference between sporadic and hereditary gene mutations. So why would you do testing on a tumor if we can't figure it out? Well, sometimes the reason you do genetic testing on tumor samples is because of personalized medicine. And more, we're trying to figure out if there are different ways to treat a cancer based on genetic mutations in the tumor samples. So if you're missing genes in the tumor, are there better treatments? And one of the things that a lot of research has gone into is if someone's missing the MLH1 protein or the MLH1 gene mutation in the tumor, would they benefit from treatments that we call immunotherapy that can boost up their immune response to fight a cancer? And they seem to respond better to that than someone who may not have this gene mutation. A lot of these treatments are still under research, or you have to be in a clinical trial, but that's the reason why we sometimes look at a tumor to sequence the genes and see whether there's any mutations in it. So the question is all stomach hereditary? And the answer is no, that's a myth. Not all cancer is hereditary. In fact, 85 to 90% of stomach cancer is not hereditary. We would call that sporadic. And the reason people get stomach cancer isn't entirely clear, but some of the risk factors include things like smoking, things like a bacteria in your stomach that we call H. pylori. Certain geographical areas in the world have a higher risk, like Japan, and that might be due to some of the diet that they have, which is more raw and smoked food. And some of it's due to aging. As our cells age, they don't divide as well. They make some mistakes, and so we have more cancer as we age. About 10% of stomach cancer is what we call familial. Familial doesn't mean that you were born with a genetic mutation. Familial could just mean that your family all has shared environmental risk. Maybe you all have H. pylori. Maybe you were all exposed to an environmental risk, and that's why we see more cancer in your family, but it's not necessarily a problem with the gene that you were born with. So that leaves maybe 1 to 3% of stomach cancer is actually hereditary, meaning you were born with a genetic mutation that put you at higher risk to develop stomach cancer and usually other types of cancers. And some of the evidence that not all cancer is hereditary is that overall, stomach cancer is on the decline in Canada and really around the world. So there's a little caveat because there are certain pockets that are on the rise, including people with young ages of stomach cancer. But in general, stomach cancer is on the decline, and that could be because there's been a decrease in smoking in the population. There's decrease in H. pylori or better treatment of H. pylori. There's changes in the food preservation. So you can see that if we switch up some of the environmental factors, we reduce the risk of cancer. So it's not just about something being hereditary. And this is a study, I put in some studies for you in case those people are interested in looking up research. There are certain areas in Canada that still do have higher risks in certain rural areas, certain provinces, in the Hispanic community, which are perhaps newer immigrants, and people with lower socioeconomic status. Another important point is that not all stomach cancer is the same. So if someone comes in and says, I had stomach cancer, do you think it's hereditary? We need to do a little bit more research on what they mean when they say stomach cancer. So for me, some of the things I look at are the pathology. So what does this look like under a microscope? Which types of cells have developed into the cancer? Are they the cells that line the stomach, which would lead to adenocarcinoma? Are they cells of the connective tissue, which we would call a sarcoma or a GIST, maybe in the stomach? Could it be cells that have something to do with the lymphatic system or the blood, which would be lymphoma, so maybe a MALT. And there are other kinds of stomach cancers as well. So depending on the pathology, we might consider different hereditary syndromes or rule out hereditary syndromes. And if this is an adenocarcinoma, we look further. So really under the microscope, what kind of adenocarcinoma is it? Is it one that looks like what we call an intestinal type adenocarcinoma, or is it a diffuse type adenocarcinoma? And pathologists would be able to tell us which one these are. And depending on which type of adenocarcinoma, we might think of different hereditary syndromes. So pathology makes a big difference to us when we assess a family. We also look at location. So where exactly did the cancer grow in the stomach? Did it grow right at the esophagus or at the junction between the esophagus and the stomach, which is up at the top? Did it grow in the proximal stomach, near the top of the stomach, in the fundus or the body? Did it grow in the distal part of the stomach? And we look at all of these different areas. In fact, certain hereditary syndromes will only grow in the fundus or the body. So we take a look at the location of the cancer as well. And then in 2014, there was a paper that came out that said there's actually a difference in the genetics of certain types of cancer. So these are somatic mutations or not hereditary mutations, but some of the tumors have this MSI feature, which is referring somewhat to the MLH1 gene problem that I mentioned. Other ones have mutations in the TP53 gene, which I mentioned earlier on, sporadic mutations. So there's also molecular changes to the cancer. So we look at all of these things, plus we look at the age of onset. Were they young, younger than expected? Did they have a family history of cancer? Do they have a personal history of more than one cancer? And we take all that into account when we try and think about what could be a hereditary syndrome. So would we say that all stomach cancer diagnosed at young ages are hereditary? And the answer is no, not all young cancers are hereditary either. I did mention before that early onset stomach cancer seems to be on the rise. So over 30% of stomach cancers in the States are diagnosed under age 60, which some would define as early onset. They have a certain look to them. So more are the diffuse type adenocarcinoma, more are near the top of the stomach, which is what we call proximal. It's more common in men, and genetically they might look a little different than the older onset ones. And then the question that comes up is, why is there an increase in these early onset stomach cancers? And the answer is, we don't really understand it, but it's probably not something that would be answered by hereditary answers, a hereditary syndrome, which is usually passed through generation to generation. So it wouldn't just pop up right now in 2022 or 2020 or 2019 even. some of the theories to maybe why there's a rise is there's changes to our microbiome, which is the natural bacteria that live in our gut that help our gut maintain a healthy balance. And because there's an increased risk of what we call PPI, which are protein pump inhibitors, which is a kind of a medication people might take for gastric reflux, maybe that reduces the amount of acid production in our stomach, which may lead to an environment that bad bacteria can grow, which can maybe cause inflammation. Or maybe it has something to do with increase in our take of medications like NSAIDs, which are anti-inflammatory drugs like aspirin, or statin drugs. Or maybe there's what we call a polygenic risk score, which might be a new word for you. And it's sort of the new way we're thinking in genetics is maybe there's lots and lots of little genetic mutations that occur. Maybe some are hereditary, and maybe some are sporadic, and in combination, and maybe in combination with other environmental risks like H. pylori, that's why there's an increase. But the answer is we don't really know why there's an increase, but it's probably not a new hereditary syndrome causing it. This is a study in Spain that looked at early onset gastric cancer diagnosed under age 50. And what they found is the same as I was showing you in the last one, that the majority of these cancers were diffuse type. Most of them were advanced. Probably because people don't investigate stomach cancer in young people when they present with, heartburn or some of their concerns. People might think they have an ulcer, they might think they have H. pylori, but they might not realize that someone so young could get a stomach cancer. And of course, we know that they can. But the important thing from this study that I thought was that only 15% of them had family history, and only 4% of all of these 309 people met criteria for genetic testing. So a very small proportion they thought might have a hereditary condition. When they looked at the tumors of these patients, only 3% had that MLH1 protein missing in the tumor, and none were because of Lynch syndrome. So they were all sporadic reasons. And of the 16 people that did have genetic testing, 4 had mutations, and they were in a variety of different genes. So I'll go over some of these genes after to show you what these genes are. But what it shows you is very few, and mind you, they didn't test everybody, so maybe there would have been more mutations found, but a small proportion, even of the young gastric cancer patients, have hereditary syndromes. And this is a paper that we published in 2020 from our group, and it represents a lot of the Ontario gastric patients, is that even if we focus specifically on diffuse gastric cancer, of the patients that we saw who were diagnosed under age 40, so in their 30s or 20s, we didn't find a single mutation in that group of people. And as you started adding on more information, so they had multiple cases of diffuse gastric cancer in the family, or they might have had some lobular breast cancer in the family, we were picking up a little bit more. So the highest rate that we would find a mutation is if they had both diffuse gastric cancer and they had lobular breast cancer and someone was diagnosed young, we found almost a 40% pickup of mutations. But it meant that there's a lot of criteria in that family that we would be able to identify something hereditary. The people who come to us and have stomach cancer at age 25 and have no history of cancer, often those are the patients that we can't find a hereditary syndrome. And it doesn't necessarily mean there isn't one. Maybe we're missing something because our testing isn't able to capture 100% of syndromes, or maybe there's something else going on with the environment that's putting people at risk. So what are some of the syndromes that cause hereditary stomach cancer? So the meat of my talk today, and I've listed a bunch here. So we used to think that there was really only one syndrome that caused hereditary stomach cancer. And as we learn more and more about the different families we're testing, we're finding there's a lot more syndromes that cause hereditary stomach cancer. But the ones that the primary cancer in the syndrome is stomach cancer are the ones here, the CDH1 gene, which causes hereditary diffuse stomach cancer. There's another gene that works with CDH1 that we call CTNNA1. It's incredibly rare that we find mutations in it, but that also can cause an increased risk. And there's a syndrome that we call GAP. So I'm going to talk a lot about those, and I'll mention some of the other syndromes listed here. So let's start with the hereditary diffuse gastric cancer syndrome, which is the most common cause of hereditary stomach cancer, even though it only accounts for maybe 1% of the stomach cancers that we see. So as I mentioned, there's a specific kind of stomach cancer we see in these families. They get the diffuse type of adenocarcinoma. This kind of stomach cancer can tend to grow under the lining of the stomach. So it can be really hard to see, even when you do a scope to look down into the stomach. The lining might look okay to the endoscopist who's looking, but if you were to do a CT scan, you might see some thickening of the wall because the cancer is growing under the lining of the stomach, and it grows diffusely, which means widespread. So it's a pretty tricky cancer to detect, and it's a pretty tricky cancer to treat. If someone is born with a mutation in the CDH1 gene, this is a picture of our chromosomes, which we have in every single cell of our body. We have 23 pairs of chromosomes, and the CDH1 gene sits on chromosome 16, which is in both men and women. There's no difference in gender, who has a chromosome 16 and who has a CDH1 gene. We actually have 2 copies of CDH1 because we have 2 copies of chromosome 16. We get 1 copy from our mom and 1 copy from our dad. So this syndrome is caused because you're born with a mutation in 1 copy of your gene inherited from one of your parents. And as I mentioned, there's a similar gene called CTNNA1. So this CDH1 gene, it codes for a protein, as all of our genes do. And the name of the protein it codes for is called ECadherent. So sometimes this syndrome, and sometimes people refer to problems with the ECadherent gene, but ECadherent is the protein. And the CTNNN1 gene codes for an alpha cadherent, so they kind of work together in the same pathway. If you're born with a mutation in that gene, there's a 50-50 chance that you could pass it down to your children. There's a 50-50 chance that your brothers or sisters might have this mutation, and there's a very good chance, most likely, that one of your parents has the mutation as well. So when we discover it, it becomes important for the whole family to be informed because there could be a risk there. So what does the ECadherent protein do? Well, it helps us, it helps the cells figure out when it's encroaching onto neighbor cells. So it basically is helping with our growth. So it prevents bad neighbor cells. It prevents it from spreading out too far and going into other areas. This is one thing that the CDH1 gene does. We've learned since that there are other things that the CDH1 gene does, but this is one of the things. We call it a cell adhesion protein because it makes us make sure our cells don't encroach in other areas. And when it doesn't work, our cells don't recognize its boundaries and starts to grow out of control. The risk associated with hereditary diffuse gastric cancer syndrome, which is the name of the genetic condition caused by a CDH1 mutation, is there's a risk to develop this type of stomach cancer. We used to quote about a 60 to 80% chance to develop stomach cancer. And we know that that's probably not true anymore. And the reason it's not true is because almost all the families that we first identified CDH1 in back in 2015, 2016, were all families that were referred to genetics because they had a really high risk of stomach cancer. And so we were kind of biased in what we looked at, meaning our families had a lot of stomach cancer, and therefore when we found the mutation, we said, guess what, you're at high risk for stomach cancer. But genetics has really evolved in the last few years where we're starting to do CDH1 testing on people who don't have stomach cancer because we're able to do a panel of multiple genes, and we do it for lots of indications. So the CDH1 gene is on the colon cancer panel. It's on the breast and ovarian cancer panel, the prostate cancer panel. It's on a bunch of different panels. And so sometimes the person being tested has no history of stomach cancer at all in themselves or their family. And therefore, we've adjusted the risk to say, well, maybe CDH1 doesn't cause as much stomach cancer as we think. So now the revised risks are probably somewhere between 30 to 40%, although if someone has a very strong history of stomach cancer, we'd likely still quote a higher risk than that. And the other cancer that we know goes along with this syndrome when you have a CDH1 mutation is breast cancer, but specifically this type of breast cancer that we call lobular breast cancer. So those are the 2 main cancers. Some people are suggesting we change the name of the syndrome to hereditary diffuse gastric and lobular breast cancer, and that's starting to catch on a little bit more because we don't want people to forget that there's this breast cancer risk, which may actually be higher than even the stomach cancer risk in these families. There used to be debate, is there a colon cancer risk? Are there prostate cancer risk? And the truth is, if there are, we don't think it increases the risk greatly. We also have learned that sometimes this gene mutation is associated with a very rare genetic condition, and it can cause cleft lip and palate, which is when your lip and your palate don't fuse properly during your development as an embryo. And so there's often a separation in your lip or a separation in your palate, which is the upper roof of your mouth. And you've probably seen pictures of kids who might have cleft lip and palate. So whenever that's present in a family, we sometimes, especially in the presence of stomach cancer and breast cancer, will think of CDH1. So given all that we're learning about CDH1, we're kind of categorizing our families a little bit differently now. So now we say, well, is the CDH1 family that we're seeing one that has stomach cancer in it, in themselves or in their family members? Or is it a family where they've only had breast cancer reported and no stomach cancer that they know of? Or is it a family that has never had breast cancer or lobular breast cancer or diffuse gastric cancer? And how would these change our recommendations? That's where our thinking is going right now. What we know is that in the families that have stomach cancer reported in the family, if you were to do an upper scope, you probably would come across a signet ring cell carcinoma, which is the microscopic stomach cancer that you would find on a random biopsy in maybe 18% of the patients. And some of the groups who do this very often find it actually even more than the 18%. And the more interesting thing is if these patients go on to have their stomachs removed as a risk-reducing surgery, meaning they weren't diagnosed with stomach cancer, maybe they didn't even have a random biopsy that came back showing cancer, but they decided to get their stomach out anyways, almost 90% of them will find these microscopic stomach cancers. So we know that the screening is going to miss these microscopic cancers because it's a little like looking for a needle in a haystack. Not quite that bad, but it's looking for something that we can't see and we're guessing and hoping we could find it. For the lobular breast cancer families and the families with neither of these two types, we still pick up these microscopic signet ring cell carcinomas when we do the scope. And when they have their stomachs out, if they have their stomachs out, we still see the majority of them have microscopic stomach cancer. Maybe not to the same percentage as the families with stomach cancer, but still a very high percentage have microscopic stomach cancer. So now the question is, why is that? Is there a difference between when the microscopic stomach cancer starts to grow into an invasive stomach cancer, which is much worse, and that's when it becomes more dangerous, when the stomach cancer starts to grow and could invade the stomach and other organ systems. What is the thing that triggers that to happen? And is the trigger something different in the families with stomach cancer in it than the families that never reported stomach cancer? Is it possible the families with the lobular breast cancer only just have microscopic stomach cancer lesions, but they never would have become invasive? We really need to figure out what that trigger is, because having microscopic signet ring cell carcinoma doesn't seem to be the danger. The danger is when that gets triggered to becoming cancer. And since we can't predict how that happens and who that happens to, we never want to take a chance. And so we recommend the surgery. But there might be differences in these families. Or is it possible that the families with only lobular breast cancer, or none of these cancers known, don't know their family histories as well? So maybe they don't know somebody had stomach cancer. Maybe someone died at a young age. Maybe they lived in a different country. Maybe their families aren't sharing the information. And so, you know, sometimes we look at the mutation, and I know that there's another branch of the family they don't know about that had stomach cancer in it, because we run a registry, and I can't share that information, but I am aware there's a risk that they're not aware of. And so it's very complex why these families present the way they do. The first step, no matter which family type you present with, if you have a CDH1 mutation, we recommend doing an upper scope, which is also called an upper endoscopy or an EGD, or an esophageal gastroduodenoscopy, which is a scope that they put down into your stomach. You get it done with a gastroenterologist or a surgeon, and they take a look at your stomach. They would look for multiple things, including whether someone has this bacteria H. pylori, whether there's any inflammation in the stomach, and then they proceed to do random biopsies. And there's a protocol that was established in England called the Cambridge Protocol, and that was agreed upon by all the world experts, that said you should do it in the different areas of the stomach. So it's not just pick 30 spots and do it, but you need to make sure you're getting a little bit from all the different areas of the stomach. In 2020, they actually updated it to say maybe instead of 5 biopsies from the body of the stomach, which is where we see a lot of these signet ring cells in our CDH1 patients, take 10 biopsies from that area. And so what I would say about this is it's really important to go to a center that specializes in doing this kind of screening. It takes longer to do the screening. You're doing a lot of biopsies. You want to be in really good hands with someone who has some familiarity with what they're looking for. Maybe what areas of the stomach, maybe there's a pale area of the stomach that looks suspicious to them because they've done this so many times. So you want to make sure you go to a specialized center, not just do an endoscopy that someone does a quick biopsy. You really need to go to someone who knows what they're doing. I'm just going to mention this. There's a lot of research being done at the NIH, which is the National Institute of Health in Bethesda, under Dr. Jeremy Davis, who has a big interest in CDH1. They've come up with this new protocol called the Bethesda screening protocol, and they do biopsies, about 88 biopsies from 22 areas of the stomach, so they map the stomach out. They report finding stomach cancer, these signet ring cells, in about 53% of patients, so they might have a better pickup rate. They do see most of them are found in the top of the stomach, but we really don't have a good study yet that compares this type of protocol to our Cambridge protocol. So I would say most of the world experts are still recommending the Cambridge protocol, but the NIH is looking very closely into whether their Bethesda protocol might be comparable or better to the Cambridge protocol. I know we're not doing this yet in Ontario. They do have research at the NIH, although I don't know if they're recruiting for this particular randomized trial, but they are looking at things like that. And the NIH, based on some of their information, might propose different things as far as screening. So if they don't see these signet ring cells, they would say go back for another year. If they do, depending on what these signet ring cells look like under the microscope, they might recommend someone go right for surgery, or they might say, come back in 6 months, let's keep looking at it. So the protocol that they're designing might look different from what we're saying right now. But really, we're waiting for more evidence to see how this fares against the current protocol, the Cambridge protocol. So I talked a bit about the risk to do the endoscopy and how the risk as far as not finding cancers, because they could still be hidden. And so often we have conversations with patients about doing this risk-reducing surgery or prophylactic surgery. And again, we kind of divide how strongly we recommend this based on the family history. So if there's known stomach cancer in the family, then we recommend that they speak to a surgeon and consider having the surgery, because we know we're going to miss a signet ring cell carcinoma, very likely. In the families with just lobular breast cancer, we recommend the screening and that they at least consider having surgery, maybe speak to a surgeon to see what the risk and benefits are to doing it. The families that have no diffuse gastric or lobular breast cancer, we recommend doing the screening, the endoscopy screening through Cambridge protocol. And if we find that they have a biopsy that comes back showing microscopic signet ring cell, then we might put them more towards the category of consider surgery at this point. And with all of our families, we recommend high-risk breast cancer screening, which would involve yearly MRI mammograms, and to consider maybe doing risk-reducing mastectomies to reduce the risk of breast cancer. If you do testing for a family that looks really suspicious and you don't find any mutations, what we recommend is that they do stomach screening every year for at least 2 years, and then you might want to extend the interval. But the truth is, if the family meets the criteria that we would offer genetic testing for in our study in Toronto, we would actually screen them yearly with the Cambridge protocol. I'm just showing you, this is the paper from 2020 where they outline the whole, who should be screened and what should be screened and do they have a family history or not. So it's quite extensive, but I've explained it all to you in my own little cartoon slides. But if you're interested, this is where you would look for it. And there has been an evolution about who we consider at high risk for CDH1. So back in 1999, we said, okay, if a family had 2 people in the family, 2 relatives with confirmed diffuse gastric cancer, we would consider that high risk. But one of them has to be under age 50. Otherwise, we need to see that there's 3 confirmed diffuse gastric cancers. And that is not easy to do, because somebody might come and say, listen, I know that my uncle had stomach cancer, but I don't speak to my uncle's family and he passed away. So there may not be any way to confirm through pathology it was a diffuse gastric cancer. And if you can't confirm it, you no longer meet that criteria. And so in 2020, in that paper that I just showed that flowchart before, they outlined different criteria that we don't always have to confirm all the cases of diffuse gastric cancer, or if you've confirmed 2 gastric cancers, one of them has to be diffuse, but they got rid of the age limitation. They said you should test anybody with diffuse gastric cancer under 50, anybody with cleft lip and palate, who has a family history, anybody who has 2 cases of lobular breast cancer in the family, under 70, and so forth. So they really expanded the criteria. And in Ontario, and I know not everybody here is from Ontario, but just to give you a sense of how we've adapted, in 2021, we came up with these criteria saying, we agree, anyone with gastric cancer or cancer of the gastroesophageal junction, or GEJ, who are diagnosed at 50 or under, we would test. And we're not saying they have to be confirmed diffuse gastric. This is really any gastric cancer diagnosed at a young age. And then we adapted everything else, including cleft lip and palate and so forth. So that's all I'm going to say about the HDGC syndrome. I'm going to move on to the polyposis conditions. So this is a newer genetic condition that we call GAPS. And what GAPS is, it's a genetic condition where people develop lots and lots of polyps in their stomach that we call fundogland polyps, not surprisingly, because they often grow in the fundus of the stomach. And these patients can grow hundreds of these polyps in their stomach. So GAPS is, it's a long name, gastric adenocarcinoma proximal polyposis of the stomach, because it grows in the proximal or top part of the stomach. And these patients have mutations in a gene called APC. APC is a gene we've known about for a long time. It causes traditionally polyps in the colon, hundreds of polyps in the colon, that leads to a genetic condition called FAP. But these patients actually get mutations in a different area of this gene that we call their promoter region. And so we only started testing for this area of the APC gene last year. So anyone who came to genetics before that may not have had the proper testing for GAPS. If someone had come to us with lots of fundogland polyps, we may not have done the right testing for them at the time. This is a dominant syndrome, meaning there's a 50-50 chance to pass it down to your children. There's a very high risk of stomach cancer. We almost always recommend that they get prophylactic surgery. And they may or may not have the colon polyps associated with it. So adding to the criteria, and I just gave this paper from 2022, which is a really nice review paper actually of hereditary stomach cancer. In 1999, they came up with some criteria saying for people with familial intestinal type gastric cancer, that's FIGC, we would consider a family at high risk if they have at least 3 relatives over multiple generations with somebody diagnosed young. But even if we see that, there's no gene that we know of that really explains primarily hereditary stomach cancer. And that's still true, actually. We don't know what gene causes that. But in 2018, they started outlining the fundogland polyposis criteria, meaning anyone who has more than 100 of these polyps in their proximal colon, in their proximal stomach rather, and especially if they're not on this protein pump inhibitor, which is that medication that impacts reflux, because we know that protein pump inhibitor causes fundogland polyps. So it's actually really, really common to see fundogland polyps in people that take this reflux medication. The question is, if they're starting to get 30 or 40 or 50 and hundreds, then we really start wondering, could it be a hereditary syndrome? So this is the Ontario criteria that just got updated last year. And these are all the genes we now include on our gastric panel. At one time, if you came to genetics, it might have only been CDH1, but now we include all of these genes because they've all been associated with stomach cancer. This is just a list of some other syndromes. They don't primarily cause stomach cancer. They primarily cause colon polyps to develop. And if you present to us and you have no colon polyps, we really wouldn't consider one of these syndromes. But if you do have one of these genetic conditions, it does increase your risk for developing stomach cancer. And especially with the familial adenomatous polyposis, the first one, FAP, that's caused by a mutation in the gene I just mentioned, APC, which causes gaps in a different area of the gene. But they also, people with FAP do get lots of fundus gland polyps. They don't necessarily have the same high risk of stomach cancer as our GAPS patients do, but they do get a lot of fundus gland polyps. And actually, so do the people with juvenile polyposis. With a certain gene mutation, they have about a 20% risk of getting stomach cancer. So these are important syndromes for a genetic clinic to be aware of. These genes are all on our panel now, but without the colon polyps, we wouldn't necessarily think about them. But it is important for us to think about, if someone's diagnosed young with stomach cancer, do they have colon polyps? So it's always a question that we ask. And some of them have other features too. So this one syndrome, Peutz-Jeghers, they tend to get freckling on their fingers and inside their mouth, inside on their lip, inside their mucosa. So if this is ever seen, and sometimes it's seen by a dentist, then we might consider Peutz-Jeghers syndrome for someone like this, who presents like this. Just a few words about Lynch syndrome. I mentioned this earlier in my talk. Lynch syndrome is really mainly a hereditary colon and endometrial cancer syndrome, but it can increase the risk for stomach cancer. It's caused by a mutation in one of 5 different genes, and depending which gene is impacted, the cancer risks would differ. But all of these genes are what we call our mismatch repair genes. So their job is, when a cell divides, it goes in and fixes any problems with the DNA during replication. And when they don't work, the cells acquire lots and lots of mutations. And so that's why the cells start growing out of control. So we do see stomach cancer in our Lynch syndrome families. It's more common in one of the genes called MSH2. It's more common in certain areas of the world where we just naturally see more stomach cancer. It's more common in men. But really, if someone presented and they had no colon cancer and no endometrial, which is cancer of the womb, they have none of those cancers in the family, there's a very low chance it would be Lynch syndrome. And the risk for stomach cancer, while is much higher than the general population, it doesn't reach the levels that the colon and endometrial cancer risks are, which are closer to 50 to 60%. If you have Lynch syndrome, we also screen, but we wouldn't use something like the Cambridge protocol, because the cancer in Lynch syndrome can be the intestinal types, which is more associated with inflammation. So we might say, do a baseline upper scope, this EGD, rule out H. pylori, make sure there's no inflammation. Consider that at 40 years old or earlier if you do have a family history of stomach cancer. And then if you do have a family history of stomach cancer, maybe consider following up or follow up based on what they find in the screening. But the exact protocol isn't as well established for Lynch syndrome because, first of all, we don't know how well an upper endoscopy works at finding cancer when it's still treatable. And we don't really know who exactly is at risk for stomach cancer if they don't present with a family history. There are a few other conditions that are coming into our periphery, and they mostly are associated with hereditary breast cancer syndromes, which I guess maybe wouldn't surprise you since I talked about CDH1, which is breast and gastric. Maybe the genes overlap in these areas. But this is a syndrome called Hereditary Breast-Ovarian Cancer syndrome. Sometimes people associate this one with Angelina Jolie. She has a mutation in BRCA2, and it increases the risk primarily for breast and ovarian cancer. It's not known that gastric cancer is at a much higher risk in these families, but I can tell you from many of the families that I see, and I see almost all the gastric cancer families in the downtown Toronto core, and I also see almost all the hereditary stomach cancer families in the province, we're starting to see a few more with BRCA2 mutations. And so this is a family with a BRCA2 mutation. So you expect to see a lot of breast and ovarian cancer running through the generations. This is a family that has BRCA2, but you can see that DGC is diffuse gastric cancer. So there was a diffuse gastric cancer, their child had gastric cancer at 21, and there was a history of breast cancer. So this family, even though they're BRCA2, was a little bit more predominantly stomach cancer running through. And just to round out, I mentioned Li-Fraumeni at the top of my talk, which is mutations in the TP53 gene. These families tend to get childhood cancers like sarcomas, some brain cancer. But since this gene is so important in cancer development, we do see stomach cancer at an increased risk in Li-Fraumeni. It's a very rare syndrome though. So common questions that I get: how are patients referred to genetics? Usually your oncologist or surgeon or gastroenterologist or family doctor would notice that you're diagnosed young or that you have a family history, and they would find a local genetic clinic that they can refer you to. And the genetic counselor would assess to see if you're eligible for genetic testing. We tend to start our genetic testing, if possible, on someone with cancer. And that's because we know that when we test 25-year-olds with stomach cancer, a lot of time the results come back normal. So we're not sure whether there's a hereditary syndrome or whether this is environmental, or maybe we missed a mutation. So if we started testing on someone who is unaffected, then the third possibility is, if we would have tested the right person, would we have identified the mutation? And therefore, on the unaffected person, their result would be so much more informative, because we could say, yeah, your sister with stomach cancer had a mutation that you didn't inherit, and therefore we're not worried about your stomach cancer risk anymore. But if we didn't do that step, we really would be scratching our heads to interpret what those results mean. We are starting to test some unaffected people, but they really have to have a pretty significant family history for us to test. If you had genetic testing and it was normal, it doesn't mean it's not hereditary, because as I said, we're not testing 20,000 genes. We're testing about 19 or 17 of them. So we're missing a bunch of genes that we haven't discovered yet. And if you had testing years ago, let's say it was normal 5 years ago, should you be retested? And the answer is yes, because we're finding new genes, we're finding new techniques, and so we're able to discover some things we didn't know about before. I mentioned if you're unaffected, sometimes you can still have genetic testing if your family history is concerning. And a genetic clinic would be really good at helping to look for some of these other features like Lynch syndrome or other genes and syndromes that we might know is associated with stomach cancer. So I'm going to stop there because I'm sure there's lots of questions, and hopefully take some of the questions that I didn't get to answer during my talk.
Thank you so much, Melyssa. That's you have a gift for essentially taking something so complex and making it so accessible. So thank you so much. I always learn so much from you. So we have a couple of questions from the audience that were kind of asked before your talk, but you did cover some of them, but I'll still ask them to make sure that everyone has a chance to understand. So the first question is, what is the minimum age for genetic testing?
That's a great question. We tend to, if the syndrome is primarily affecting adults, meaning it's not going to impact children, there's no treatment in children, there's no screening in children, then we wait till people are 18 so that because they have the right to make their own medical decisions, their parents shouldn't make the decision about whether they should have genetic testing. They should be an adult to make their own decision. Since it's not going to impact them as a child, they should get to the age of majority and make their own decision. So generally 18 is the age we will test. But there are certain syndromes like FAP that impact kids, and we have to start screening when you're a kid. So we will test younger, like around 10 years old. Or if ever there's a cancer in the family that's younger than, let's say somebody had colon cancer at 25 and we want to start screening 10 years younger than that, well, that puts you at 15. So we might want to start doing genetic testing younger to see really when you're eligible to start your screening.
Okay, thank you. So I know that you covered this a little bit, but maybe you can elaborate. So this person has had genetic counseling done and nothing was found. As we move out more years, should my kids undergo genetic testing again in 5 to 10 years? And I guess just to elaborate, how would they do that? Would they refer back to the genetics counselor? Would they go through their doctor? What is the process?
Yes, that's a good question. So I'm sort of making an assumption here that the person who had genetic testing is the person who's affected. So it would be best if they went back in 5 years to get genetic testing, because if their testing was normal, then if you test their children, the children's genetic test would be normal, and that really doesn't help us assess their risk in any way. But as I said, testing changes and evolves. So the person who tested negative, or that means a normal result, I know people have learned that through COVID. One thing I can thank COVID for is people understand a negative result versus positive result. But if the result was negative, meaning good, then they might want to go back in 5 years because they might want to see whether there's new genes available. Often a genetic counselor will include a paragraph saying things could change, please contact us periodically. So you are welcome to recontact your genetic counselor directly. If you forget who your genetic counselor is or you've moved, then just ask your family doctor or any of your doctors to make a referral to a local genetic clinic and they will be able to help you.
And how fast is the science moving? Is it every year, every 2 years, every 10 years?
Well, yeah, that's a good question. Every few years, you know, I sort of feel like in the last year, I sit on the many committees at Ontario Health and the Ministry of Health. There's been an explosion in what we're doing in genetics. So introducing new panels, introducing who we can test for. There's a lot of conferences now on hereditary stomach cancer. And as I said, even CDH1, if you listen to older talks of mine, I didn't maybe break it down as much. You know, I'm seeing people now who have no diffuse gastric, no lobular breast cancer and CDH1. So the genetics is changing, our understanding is changing, the screening might be changing. So, and also our understanding of what happens after prophylactic surgery. What kind of micronutrient deficiencies do we have to look for? Do we have to look for osteoporosis? Do we have to do bone density tests? All those things we still need to sort of research. And so there are a lot of things that you might want to get updated on if it's been a little while since you've had a genetic consult.
So I just have a couple of follow-up questions with respect to the 5-year and 10-year or something. So as most people know, I think on this who are watching, I have Lynch syndrome and I've had stomach cancer. So one member of my family tested positive as well, but my other sibling did not. So a couple of things. Should the one that tested positive retest because it's been almost 10 years? And should the one that tested negative retest? And should I?
I love this question, Teresa. It's a great question. The fact is, if we tested your gene and we found a mutation that you were born, that's in all the cells of your body, that never changes. You don't have to come back in 10 years. You have the same exact mutation. Nothing will be different. So if the mutation, the genetic mutation found explains your family history of cancer, meaning you have Lynch syndrome, you have a family history of colon and endometrial, and maybe some of the other cancers we know are in Lynch, that makes sense. Then there's no need to come back in 10 years. We're not going to find anything differently. But let's say your family history also had a lot of breast cancer in it, which isn't typically explained by Lynch syndrome. You might come back and say, listen, should I be tested for the breast cancer genes? Nobody did that. And my family history of cancer is not entirely explained by Lynch syndrome. And we have some families that have both Lynch and hereditary breast-ovarian cancer syndrome. So sometimes people come back to get reassessed because maybe there's something not explained in the family. If someone tests negative for a family mutation, it's the same answer. If they didn't have it 10 years ago, then they don't have it now. And if you were given a result that says, we found exactly what caused your cancer, then you have your answer. It's really the people who either there's more cancers, maybe I often get calls saying, someone was just diagnosed with an adrenal cancer. Is that Lynch syndrome? Should I be tested for other genes? And I'll say, yeah, there are genes associated with adrenal, which is a gland that sits on the kidney. Yeah, you should come back. Or they might say, someone in my family got stomach cancer and they tested negative for the Lynch gene. Should they be retested? And I'll say, yeah, because that, I wonder what's going on there. Let's just double check that it really wasn't an error in the lab, you know? So we've had people come back because they've developed a cancer after testing negative. Almost always our result was correct and it had nothing to do with Lynch syndrome, but sometimes we'll go, yeah, let's go back and just make doubly sure. In this family, because of anxiety and because they're probably worried about it, that goes a long way also psychologically for us to say, let's reassure them that it's really not there and that they don't have to go in for Lynch screening. Does that answer your question?
Yeah, and does that hold true for some of the other genetic syndromes?
Mm-hmm. It holds true for all of them, really.
Okay. Yeah. Okay.
So I'm noticing that there's a couple of clinicians as part of the participants. And this is a question that I think clinicians have, including myself. So I'm lucky to know you in the downtown core. So for me, it's as easy as sending you an email and saying, which patients are appropriate. How would people in more kind of remote hospital systems go about referring to genetic testing?
Yeah, that's a good question. We actually just revised our referral sheet to list every criteria so that people, if you can't check it off, chances are your patient's not going to be eligible, but at least it gives them a sense of it. The testing in Ontario, so I'm speaking specifically for Ontario now, every province has their own rules about who they can test. In the States, they have their own rules about who you can test. And I didn't mention, but there are, private pay. So if people are interested in genetics, they weren't eligible through Ontario. Some people just pay for testing and get an 80 gene panel, cancer panel for testing. So there are other methods to get testing outside of genetics. But because there's been a huge change and swing in what we're testing for, we've been trying to do rounds, like go to different hospitals and sort of give talks about it, especially things like that MLH1 protein deficiency. It comes up in 20% of all stomach cancers and 15% of all colon cancers, and almost never is it Lynch syndrome. So we definitely don't want to get referrals for, someone who's 90 years old, who has no family history, because they have an MLH1 protein. It's not hereditary. And so that's the kind of thing it's helpful for us to try and educate the doctors and, family doctors and everybody else who might see this. Sometimes the surgeons don't make the referral, but it goes back to the family doctor, and then the family doctor makes the referral to us. We're like, oh no. But at this point, since there's so much growth, a lot of it is on us to help educate people. And that is exactly what we're here to do.
Great, thank you. You mentioned some for private genetic tests. Now, I'm assuming you're not talking about like 23andMe, or what kind of tests would be the appropriate way for people to go if they're considering self-pay? And again, is this something that a genetic counselor can talk to a patient about, or is this the role of the family physician or the oncology team?
Yeah, so that's a great question. 23andMe or Ancestry.com, they're not really doing genetic testing in the same way. They're looking to see, who's your family connected to. And they might do a little bit of genetic testing, but it's not thorough. It's often through research. And sometimes it's not even, we try and confirm the mutation and we can't find it. So it's not always the best way to go. I don't know if I should promote any specific lab, but there's things like DynaCare has a group called Color. That's like an 80 gene panel. There's other groups, Prevention Medicine has some. So there are labs. You want to make sure it's an accredited lab that will give you a clinical result. Often they have their own genetic counselors that work with them that will speak to the patient. So it won't come through the hospitals or the regular genetic clinic. And as part of the hospital, we don't tend to order the testing because it's outside our purview. So if we're not going to order testing ourselves, we aren't able to order it through commercial labs. That's something that patients will have to opt to do anyways. I think it costs, I want to say like $400, maybe somewhere between $200 and $400. The price has often gone down, but I would, look into some of those places, and it might go through the family doctor. I don't know how much they know about it. In genetics, we might say if someone's very insistent and we really don't think that they need genetic testing, I might say, I don't think we're going to find anything, but if you really, really, really want to do it, then here's some names of some commercial labs that you're welcome to go to, but I can't help arrange that legally through the hospital, because then we would be responsible for the results if it came back.
Right.
We have another question here. There's actually a couple of them, a number. From Terry, it has been 10 years since I was tested. I am not having mammograms. Should I be? I did not have CDH1 or Lynch syndrome.
So we always recommend mammograms as part of your general health workup as a woman. Everybody's at risk for breast cancer. Your family doctor should be arranging that. So yes, depending on your age, you need to have mammograms as a woman. Are you at risk for breast cancer just because you had stomach cancer? The answer is no, because you're only really at risk if you have a genetic syndrome where the genes are playing a role in the division of cells in the breast and the stomach. So if you have testing and you don't have any breast cancer in your family and we didn't identify a hereditary syndrome, then you would normally follow the general population guidelines for breast cancer screening. And if you had testing 10 years ago and you haven't had it since in genetics and you think you're eligible, then go back to genetics and get reevaluated. That's the same with colon cancer. So a lot of people don't have Lynch syndrome, where we do colon cancer screening on a very regular basis, but everybody needs to do colon screening. So if you have a family history of colon cancer, then you should be getting colonoscopies based on, you know, the recommendations through the Canadian Gastroenterology Association and through the American Association and so forth. If you have no history of colon cancer, depending where you live in the States, their rules are a little different. I think they say everybody should get colonoscopies no matter what your family history. In Ontario, you really have to have a family history. Otherwise, there's stool sample testing and so forth. So cancers are, as I said, 90% are sporadic, meaning we're getting them for reasons that we're all exposed to: aging, environment, diet, smoking, alcohol use, and so on. So we're all at risk. And for the very common ones, prostate, colon, breast, you really need to speak to your family doctor about getting your routine screening, cervical routine screening.
Okay, I'm getting a couple of questions about what is the process of genetic testing? So what is required? And perhaps maybe you can elaborate on, you know, what is required from the patient versus their family as well.
Yeah, so I will mention so what traditionally, this is what would happen. We would your doctor would make a referral to genetics. We would have you come down to the hospital. We would meet for an hour or so, go over your family history, go over your medical history, give you a requisition, send you for blood work, and the results would take months to get back. Now that COVID happened, we don't make people come down to the hospital anymore. We do it on the phone or virtually. The calls probably don't last a full hour anymore because people can't stay on the phone that long. So maybe half hour to 40 minutes. We email you a requisition. You get it done at a life lab or some local place. The results take about 2 months to come back because it's faster. However, in gastric cancer, we've started, at least at the downtown hospitals, and I've been trying very hard to work with some of the oncologists and surgeons to do mainstream testing, meaning the doctor will order the test directly. They will see that someone's eligible because they were diagnosed at 49 years old with stomach cancer. They hand them a requisition, they get blood drawn immediately, and the results come back to that surgeon and also to the genetic clinic. So you completely bypass genetics altogether, except we're in the periphery, we're seeing what's going on. We might contact you to do a family history, but it's a way to save people from, you know, people with stomach cancer are going through so much and they're, you know, often ill or they have to deal with chemotherapy and they don't have an hour to talk to us. So we try and get the blood drawn as quickly as possible, as easily as possible. And we try and rely on some of the other circle of care team members, like their surgeon oncologists and so forth, to do that. Because the most important person to test is the person with stomach cancer. So we don't want to lose the opportunity to test that person because we made it so hard for them to come to genetics that if they pass away, then their family members are going to come to us saying, now what do I do? And what we'll say is, we wish we would have gotten a blood sample, to be honest. So we're trying to make that easier. And if you think you're eligible because you're young, speak to your doctor about arranging genetic testing. They might be able to do it for you right then and there if they work with a genetic team. For the family, there's not much the family can do until the initial results come back. So if the results come back saying, we discovered the hereditary syndrome, now testing opens up to all family members. We will test you for the mutation identified in your family that we know causes the cancer, and you either have it or you do not have it. You're going to get a yes or no answer. But if we tested someone at 25 years old with stomach cancer and the results were normal, there's no point testing her sister because those results are going to be normal. And I don't feel any better about saying, oh, well, then I guess you have no risk, because the person who was diagnosed at 25 with stomach cancer also looked like they had no risk. So that doesn't help me in any way. So we don't test family members if we don't have a known syndrome identified.
Right.
We have another question here. How do I know if a center has expertise for managing hereditary gastric cancers? And then are there some in Quebec? And so just as part of that, I know in the US, there are some hereditary gastric centers. Do we have that here in Canada? And, you know, which would you not recommend, but how do you kind of go to those?
Yeah, I would say, I mean, we work with some amazing doctors. So I'll just mention Dr. Carol Swallow, who's an amazing surgeon. She's done many, many surgeries. I don't know if I don't know how many, I think about 40, but like a lot of prophylactic. And I'm just talking prophylactic stomach surgery. She's done many, many, many more surgeries, but she's done a lot of the prophylactic surgeries for our CDH1. So you want to go to someone who has, this isn't their first try at doing this. They are aware of the syndrome. They hopefully work with a supportive team. You need to have other members of the team, like a genetic counselor, like maybe a dietitian, psychology, and maybe that they can offer some peer support. So because I follow 80 CDH1 families, I can often match people to someone else who's had the surgery or decided not to have the surgery, or someone who's athletic, or someone who had a pregnancy after, because I'm familiar with a lot of people. If I've never seen a CDH1 patient before, I may not know how to connect them to someone or have that relationship. So probably just ask the genetic clinic, like, you know, how many people with CDH1 do you follow? How many surgeons, ask the surgeons, how many surgeries have you done? You know, is this a hospital that specializes in doing the Cambridge protocol? If they don't know what the Cambridge protocol is, they're probably not the right center for you. We have taken a special interest, us, Dr. Swallow, Dr. Sav Brar, Dr. Anand Govindarajan. So we're a team of people. Dr. Aaron Pollitt's our pathologist. He's looked at many, many stomach specimens after surgery, which is an art in itself. So because we all have a special interest, we created our own specialty clinic. We have people coming from all over the place in Canada to see us. I don't know all the ins and outs of all the other clinics in Canada, but you're right, there are some in the States, like at the NIH with Dr. Davis, who's a specialty clinic. And there are support groups like My Gut Feeling. You probably have links that you might know about. No Stomachs for Cancer might have. So there are support groups that might help other people. And I know you guys have worked with also young or early onset patients. You have a Facebook group for women with early onset cancer. So they, you know, people know other people. So you might want to, you know, you could always ask them about connections that they have.
Okay. While we're on the topic of NIH, Melanie has a question. So the NIH just had a 2-day webinar that's where they stated that if you have the BRCA2 gene, you stand a 50% higher risk of getting stomach cancer. Do you agree with what they are saying about the higher risk?
I don't recall them, I was at that webinar. I don't recall them saying they had a 50% higher risk. Do you mean in comparison to the general population? So if the general population is 1 to 2%, maybe their risk is 4%. So I'm not sure if they mean like 50% compared to general population. I don't know that we know the exact numbers yet of the BRCA2 population. I agree that it probably is higher, although that's anecdotally that I'm saying that. And I feel like in the webinar conference, they also said anecdotally they felt like that. They weren't, there was some discussion. So the NIH just put on a 2-day conference all on hereditary gastric cancer. And there was some discussion, should we be screening BRCA2 carriers? Specifically, they talked about BRCA2, but they also mentioned other genes like POLB2 and BRCA1. Should we be screening their stomachs? And it was sort of left that maybe we need to have discussions in that direction, but there was no firm protocol yet. So I don't know if I have a number exactly, but I do worry that there is an increased risk of stomach cancer in the BRCA2 population. It's always, you always have to be very careful when you say, I see something, therefore it must be true. Meaning someone has BRCA2 and gets stomach cancer, therefore it must be related to it. In science, we never do that because fluky things come up. So you have to see that this isn't just coincidental. You could see it in a couple families, but out of thousands of families are you seeing that trend? And that's really what we need to see. And also, is your sample biased? Like, was everybody recruited from you know, a center where they do high-risk stomach cancer screening? Or was it like a population of all BRCA2, which really are probably breast cancer? Was it, you know, so you really kind of have to look at the whole picture together, which is, you know, as I was talking about CDH1 and diffuse gastric cancer, and we used to give numbers so high for stomach cancer, it's because we were biased when we looked at it. So you really have to, and there's a lot more movement looking at a much more general population that isn't biased in one way or the other to see, is this trend of stomach cancer really, really true based on scientific calculations?
Okay. And then we have a couple more questions, and I realize we're running over time, but it's quite an engaged audience, so I want to make sure that we get through everyone. So what about variants of unknown significance? So for example, what's to do with patients who have a CDH1 mutation that is not clearly pathogenic?
Yeah, okay, so variants of unknown significance are changes in the gene that aren't clearly disease causing. We don't have enough evidence saying they definitely impact the gene and leads to the disease. And we don't have enough evidence to say it's just normal variation. There's a genetic change. All of us have genetic changes. It probably means nothing. It's somewhere in the middle, meaning there's probably been some evidence that we can't rule it out completely because let's say it's never been seen before in any population. It's probably rare then. It's in an area of the gene that's been conserved through evolution. So it's probably in a part of the gene that's important. Those would be very vague factors, but maybe factors saying maybe we should think about this. On the other hand, maybe there's evidence saying all of this, the lab work that we did or the computer models say it's not going to impact the gene. All the things that we've looked at have said it's been seen in a big population of people. It doesn't seem to be causing that, leaning more towards it's probably normal. So it means the lab hasn't come to a decision one way or the other. So for us, we don't do anything clinically based on a variant of unknown significance because we don't know what it means. It doesn't necessarily mean someone has the disease. It doesn't mean they don't have the disease. Sometimes when I read the paragraph, because the labs will always give evidence to why they're calling it a variant, I will lean more towards, it's probably not that, or I know the disease. They'll say there's a mutation in the APC gene, which I know causes FAP. This person should have hundreds of colon polyps. If they do not, and they're 60 years old, then this is not a harmful variant. I can tell you right now. Or if they have Lynch syndrome and every tumor in the family doesn't have any deficiency in, the mismatch repair proteins, it's probably not related to Lynch syndrome. So sometimes we can help a little bit. Often we look for segregation, meaning, okay, which of the parents did this come from? Do they have cancer? Do their siblings have cancer? Where is this variant coming from? Is it coming from the side of the family that's reported to have all the cancer? Or is it coming from the other side with no cancer? Maybe that would tell us it's probably not the disease-causing variant. And as we go along and more people discover these variants, we learn more and more about them. And so the variants may be reclassified. There's also some studies looking at RNA, which is so people might know about mRNA now with COVID vaccine. So our RNA helps interpret our DNA, which is our genetics. And there are some studies looking at how does this impact the RNA? Does it impact it in any way as far as how the RNA splices our DNA? If it's splicing in areas that are not coded for anything important, then I guess it's not an important variant. So we don't do RNA sequencing in Ontario, but I know there is some being done through the States. And so, and I'm hoping maybe one day we'll have some more RNA. So what I would say about a variant of unknown significance is you should be checking back with your genetic counselor periodically. You can then check back with the lab to find out, are there any changes? Do we know any more about it?
And Melyssa, there's a question I have. So what about, we haven't really discussed this, but what about the psychological effects of being diagnosed with one of these genetic syndromes? Should these centers of excellence, is that part of their sort of multidisciplinary team? And when you actually deal with the family or deal with the patient, do you offer that right off the bat, or like how does that work from sort of like the genetic, the actual institution? I mean, I know the patients, we have a support group for Lynch that I'm a part of, and I'm sure there's other support groups, but in terms of like right off the bat, when someone's completely overwhelmed with that, and this could probably be a completely different topic, I think, but I just wanted to bring that up, I think, because it's one of the things that people are kind of a little more hesitant to ask about, but it's really, really important because it's lifelong.
Yeah. So I would say most centers of excellence do work with psychologists or psychiatrists who have some expertise in hereditary syndromes. We do at Sinai. I will say these our psychologists and psychiatrists are quite overwhelmed with their workload. So we don't offer every single person referrals to psychology or psychiatry. However, if the genetic counselor is speaking to someone and we identify that they're struggling, they're very anxious, they're having trouble dealing with the results, we absolutely will offer a referral. Or if someone says, I think I need a referral, we do. Often the people that we work with will sort of get them through the initial, so you found out you had a hereditary syndrome, you know, let me help you with this sort of acute phase, like right now where you're just starting to deal with it. But if you need long-term help, often that's something that your family doctor would refer you to a mental health specialist for, because our doctors aren't really set up to follow people long-term for hereditary cancer concerns. So we do investigate. We send out a questionnaire. We haven't so much for COVID, but we do ask if people suffer from mental illness, which might be an indicator that once they get results back, they might have a harder time dealing with it. If they suffer from anxiety, this might provoke their anxiety. And we do check in with people, you know, to see how they're handling the information. We try and make ourselves available. If they have any concerns, they're certainly welcome to call us. And if we identify a problem, and that's why we like to talk to people during the pre-test, before they do it, to say, how do you think you'll handle these results? And if they go, I don't know if I'm gonna be able to manage these results, then we can flag it in our notes to say, when results come back, if they're positive, check in on them and see if they might need more help. And especially, I think when you're talking about having your stomachs removed, we've often had people go and speak to our psychiatrist as part of the workup to say, like, I don't know how I'm going to be able to manage this. And so, yeah, we definitely do work with someone, but it's not routinely offered to every single person that I see.
Great, thank you.
Just a follow-up question. So we talked a lot about prophylactic surgery for people that have a genetic mutation. Are there other implications clinically, for example, immunotherapy, that could be based on the information that you provide us or clinicians?
Do you mean, like, are there treatments for CDH1, or do you mean there are side effects for immunotherapy?
So, for example, with Lynch syndrome and MSI status, is there a role that would bias clinicians to, for example, give immunotherapy?
Yeah. So interesting. Somebody went to that 2-day webinar. So there was a great talk on, are there treatments that are going to become available for people with CDH1 mutations? And he actually, it was Dr. Perry Guilford, I hope I'm pronouncing that, from New Zealand, who discovered the CDH1 gene. He's done a lot of research on this. And he actually gave a couple of really interesting examples that are now being worked out in mice models. So they're not yet in clinical trials, but they are starting to show that maybe there are medications that can help. There was a medication that maybe not only helped reduce the risk of stomach cancer, but if the second allele, meaning you're born with a mutation in one of your CDH1 genes, and the reason the cancer happens is because the second copy of the CDH1 gene is knocked out, it helps restore that second copy. So he talked about, and maybe doing combinations of medications based on this drug trial. So there isn't anything yet, but there's research that's going on to look into it. So hopefully maybe one day there will be something like that. And it's always a little tricky to figure out, like, what the, if there's traditional treatment, often you have to go through the traditional treatments first. That's often how clinical trials work, but you have to kind of exhaust all the things that you would normally do. And then if that you have and it still hasn't worked, then maybe try the experimental things. We're not at that stage yet with CDH1, but maybe one day we will be. So yes, I'm hopeful they'll find something.
And so with tumors that are MSI high, and they're finding that they might respond better to immunotherapy. Like, do you have any thoughts on that, or like, how does?
So,
like, what are the numbers so far?
I actually probably don't know. It's probably a better question for an oncologist. There are a lot of studies that have looked at it and shown real benefit for patients in later stages. So they wouldn't give these therapies for people in early stages. And a lot of it looked at people who had metastatic colorectal cancer, but also some of the other kinds of cancers, to see how they work.
Gastric one of them?
Yeah, I think it was any site that was MSI, we call it high or protein deficiency for the mismatch repair proteins. That's the same kind of thing. But I still don't know if it's being given routinely, when it's being given, or if it's all part of clinical trials, and if it's for every single site, and what exactly, for clinical trials, you have to meet it exactly. So it's, you can't kind of wiggle your way into clinical trial. You know, you have to have the right health, the right treatment beforehand, the right staging, and so forth. So I'm not involved in the oncology department at Princess Margaret. So, but I always encourage people to ask their oncologist about it if they have an MSI high tumor. Same with BRCA2. So BRCA2, they have something called platinum inhibitors. And so there are some certain drugs where BRCA2 carrier might benefit from certain platinum-based drugs, which again, you'd have to speak to your oncologist about. So I'm not an expert at drug treatment. Katie, you might even know more than I do about all of it. But it's a conversation. It's good to know that there are things so that you can speak to your oncologist about it.
Yeah, I mean, I think it's a big conversation right now in terms of immunotherapy. And I think the approach depends on whether it's, curative or palliative intention. Right now, I can say that anecdotally, we are very biased in putting patients with certain types of genetic conditions. For example, if a patient has Lynch syndrome, we're very biased in putting them in one of our clinical trials that does give them the opportunity to get randomized into an immunotherapy group. Again, the research and the standard of care is still it's still up and coming, but that is our bias as clinicians, is to try to get the patient on an immunotherapy trial or get access to immunotherapy. So there's definitely implications, but it's all up and coming.
Great. So I don't think we have any more questions. If anyone thinks of a question that they do want answered, or if you just didn't, we didn't answer it, you can re-ask it and we'll send it off to Melyssa. As we said at the beginning, we will have this is being taped, and so we'll have it up as soon as possible, available for people to view who weren't available to join. I want to thank Melyssa for her time and her expertise. I also wanted to thank Taiho Pharma Canada Inc. again for their sponsorship of these education series. We will continue to have more throughout the year and keep you posted. And we want to thank those that participated. Katie, is there anything you'd like to add?
Yeah, no, I just wanted to say thank you to everyone for joining us on a Saturday. And Melyssa, like I said, amazing ability to take something so complicated and really break it down. And thank you for sitting in with all the questions and going with the punches. So yeah, thank you so much.
Thank you. Thanks for everyone for coming on a Saturday.
Thanks, everyone. Have a great weekend.
Bye.
Bye.
Bye.